So the issue with pericarditis, and we're going to kind of take a full soup to nuts approach on pericarditis here today. So pericarditis obviously is inflammation of the pericardium, and I know that we have a large variety of people in our audience today, so hospitalists, home health, hospice, cardiologists, etc. And we're not entirely sure how common pericarditis is. All of us see it, and all of us see it all the time. But the estimates are that it's about 30 per 100,000 people develop pericarditis. Probably more importantly, however, is that emergency department presentations for chest pain, about 5% of patients who present to the emergency department with chest pain have pericarditis. And we know with that 30 per 100,000 and with that 5%, we know that it is seasonal. So we know, so it's often presumed to be viral. And we also know, and we've even had scenarios when I was in Boston, we had scenarios where in a dorm, there'd be incidents of a couple of episodes of pericarditis. In a building, there'd be a couple of episodes of pericarditis. So this does feed into the fact that most of the time that acute pericarditis, which is what we're starting at, acute pericarditis is actually viral in nature or infectious in nature. However, when you start looking at it, it's actually the only about 1 in 6 have been shown. There's going to be a lot of 1 in 6s here. Only about 1 in 6 have been shown to be related to an infectious etiology. The most common being EBV, parvo, TB, and some other infections. Obviously, it's more serious, such as staph infections. You get effusive pericarditis. But despite the fact that we all assume that it's viral, and despite the fact that we all say that it's viral, we've only actually shown that in 15% of cases. 55% of cases, we're throwing a lot of numbers out, Carmela. 55% of cases are ultimately end up being truly idiopathic. You search and search and search, and you do not find an etiology. 20% of cases are caused by Jeff Turner. And they are procedure related, either ablations, most commonly ablations, and then actually Nathan causes a lot of them as well, with pacemakers, and then Anwar, who's going to talk after me, causes a lot of them as well with TAVRs. So 20% of our current pericarditis cases are actually procedure related, and this is important because our population then ultimately changes. And also it's important because the procedure related and all of these can be associated with chronic pericarditis. So about 20 to 30% of people develop recurrent pericarditis. And then about another 10% go on to develop chronic recurrent pericarditis, namely more than 2 or 3 episodes. The final etiologies that are worth remembering are cancers, and it can either be a primary cancer or a cardiac tumor, or it can be cancer, or it can be a metastasis, breast cancer, etc. And actually with that, one of the newer etiologies, and we'll stop the etiologies in a second. One of the newer etiologies are the immune checkpoint inhibitors. I know Dr. Baker and I were briefly, when we were talked about your relationship with Huntsman, etc. So the immune checkpoint inhibitors used in the treatment of malignancies, most notoriously in melanoma, have been associated with development of pericarditis. That gets particularly hard because obviously if you're on an immune checkpoint inhibitor, you are immunosuppressed. And as we touch on, much of our treatment ends up being immunosuppressants. So it just gets a little more complicated. And to quote the great Canadian poet Avril Lavigne, why do you have to go and make things so complicated? And really pericarditis has become quite complicated. To diagnose pericarditis, you need 2 out of 4 features. You need 2 out of 4 features. And those features are chest pain, pericardial rub, ECG, or effusion. Now, this is important because you only need 2 out of the 4. So you actually don't need, funnily enough, you don't need chest pain in everyone, you don't need rub in everyone, you don't need ECG changes in everyone, and you don't need evidence of an effusion in everyone. So you can have it is a clinical diagnosis. And when we do our trials, when we do our registries, the pericarditis is based on a clinical diagnosis. You can complement it with inflammatory markers, your CRP, ESR, white blood cell count. And CT and MRI imaging may be helpful as well. But again, you don't necessarily need these. The CRP, interestingly, is actually predictive of adverse outcomes. If you have an elevation in your high sensitivity CRP in particular, it is associated with worsened outcomes. So that's valuable. And if you're lucky enough to have a high CRP, you can actually use that in terms of guiding your treatment. You can treat quite aggressively while their CRP is high, and then when their CRP falls down, you can assume that maybe you can titrate off the medications. But here's your classic ECG and ECG changes. And for those who do not look at ECGs for a living, such as Dr. Tandar, and you have diffuse ST segment elevation. Diffuse ST segment elevation, and this is pathologic signs of pericarditis. There are very few other things that can cause diffuse ST segment elevation. Some of them are Takotsubo's, some of them are myocarditis. Obviously, some sort of major myocardial injury or myocardial infarction or ischemia can cause it. But ultimately, your diffuse ST segment elevation is synonymous with pericarditis. You also get, and I'll try and walk across here. It ends up getting fun on your AVR lead, or when I was in Boston, the AVR, as they would call it, the AVR. You have ST segment depression. Whoops, a daisy! Holy mother of Tom Brady! I have no. Okay, Anwar, don't touch the screen. All right. So you have ST segment depression on your AVR. You can also end up getting your PR depression as well. You can end up getting your PR depression as well, and that's again a feature of pericarditis. So ultimately, your ECG does go a long way to tell you that they have pericarditis, but it's not an absolutely necessary. And there are sequential changes that can occur with your ECG, and you can start going from your ST segment elevation, and as your stage 1, and ST segment elevation, and then this progresses, and ultimately in stage 3 you get T-wave inversion, and then your stage 4 you end up with normalization of your ECG. So the ECG can progress, however, that's only seen in about 60% of patients. Also, in actually recurrent pericarditis, only 20% of patients had any ECG changes. So we rely heavily on it, but this clinical syndrome of chest pain, usually sharp, usually actually fairly sudden in onset, often radiates to the back, oftentimes confused with aortic dissection, alleviated by leaning forward and sitting up. These are features of pericarditis. So you really rely on the clinical history. On the exam then, and this is where there is oftentimes, as I said, there's the pericardial rub. And I said there's going to be a lot of 1 in 6 over the course of our discussion. Well, guess what? Only 1 in 6 people have evidence of pericardial rub. And actually, to pick up the pericardial rub in that 1 in 6, you need to listen to that patient 6 times a day. I don't think Anwar has listened to a patient 6 times. He doesn't have a stethoscope, and if he did, he wouldn't even know how to use it. But in any case, so you really do have to auscultate pretty aggressively in order to pick up the pericardial rub. And actually, Jeff, you remember Eleni, one of Eleni's first days with us as an intern, rounded with her person had chest pain. She listened and she said she heard her rub, and I was like, "There's no way in hell you heard her rub." She was a PGY1. It's like, you haven't heard her rub, and I listened, and lo and behold, the intern heard a rub. I was like, wow, you're amazing. And then we took her into cardiology fellowship after that very day. So now there will also be, so you got your exam, and then you also look for, one of the things I didn't mention actually so far was that can also be associated with systemic diseases. So the patients are often uncomfortable, they're often febrile, they're often anxious, they're often breathing uncomfortably because they get pleuritic pain with pericarditis as well. But it can also be associated with something like lupus or rheumatoid arthritis. So you do also then look for physical exam findings of lupus or rheumatoid arthritis in order to support your diagnosis. Now, then you also look for troponin. Everyone looks for troponin, and 30% of people will have evidence of an increase in troponin. This, by definition, calls it myopericarditis or perimyocarditis, depending on what you want to call it by, and it does reflect the fact that there is some myocyte injury or myocyte death. This can also then be associated with wall motion abnormalities. Yeah, this can also be associated with wall motion abnormalities, and as you can imagine, if you have an elevated troponin, it is associated with a worsened prognosis because there is the myopericarditis or perimyocarditis going on. Finally, then, the only actually necessary testing, aside from the ones that we've mentioned so far, I guess, the only necessary testing that you need to do beyond that is an echocardiogram. And the reason to do an echocardiogram is, one, to make sure there's no wall motion abnormalities. So it's really to look at complications of the pericarditis. One is to make sure that there's no wall motion abnormalities. 2 is to make sure that they don't have pericardial effusion. 3, if they do have pericardial effusion, make sure that they're not in tamponade. So these are the reasons to do an echocardiogram on every patient. Now, 40% of the time will be normal. Most of the time they'll end up having a little pericardial effusion, then about 2 or 3% of cases there'll be cardiac tamponade. So when you're doing your diagnosis, to get there, you need your chest pain, you need your rub, you need your ECG changes, and maybe some echo findings. And 2 out of those 4 will get you most of the way there. And then you got to look for an underlying etiology. The CT and the MRI, although not mandatory in the work of pericarditis, are actually quite useful, and especially in the patients that Dr. Selzman and I have shared, where there's concerns about constrictive pericarditis, which we'll touch on subsequently, and you're applying pericardiectomy. The CT and the MRI are actually useful in those scenarios. The CT can show you pericardial calcification and show you the thickening of the pericardium. Again, I look at these for a living. Not everyone in this room does. This is your heart here, and this around here. Whoops, a daisy, holy. This is the pericardium around here, and perhaps to your untrained eye, you can appreciate that that pericardium is thickened. And then between the heart and the pericardium, there is some fluid buildup as well. So you do have pericardial effusion as well as pericardial thickening. You also have a pleural effusion down here as well, which is not uncommon. And again, feeds into the concept that maybe there's some viral injury that has irritated the visceral lining of various organs. So the CT, again, can be useful. It gets particularly useful in the chronic pericarditis. The MRI becomes useful. It's fairly nuanced. Do you do much or cardiac MRI here, or much or any cardiac MRI here?
Working on it.
Working on it. Okay. Okay. So the cardiac MRI is fairly, as you know, it's expensive, as you know, it's time consuming. And the amount of value that you get in the setting of at least acute pericarditis with cardiac MRI is a little questionable. You probably do the late gadolinium enhancement. If you have late gadolinium enhancement, which is a marker of inflammation, which is a marker of increased vascularity within the pericardium, the late gadolinium enhancement does prognosticate poorly. Namely that if you have late gadolinium enhancement, you are less likely to go into remission. You are more likely to have recurrence, you're more likely to be sicker if you have late gadolinium enhancement. And the other way that MRI is actually useful is, as I said, these symptoms are very vague. The presentation can be vague, the ECG can be vague, the echo can be vague. And if you're really scratching your head about, does this person have inflammation of their pericardium or not, then you do a cardiac MRI. And this is oftentimes where you reveal the fact that they have chronic recurrent pericarditis, which is a very debilitating condition. So that's the issue with the CT and the cardiac MRI. I don't think you necessarily need a cardiac MRI, but when you do it, and when you do have thickening of the pericardium or late gadolinium enhancement, it is helpful in order to seal your diagnosis. The other final aspect of the cardiac MRI that's useful, however, is when you are looking for constrictive pericarditis. So constrictive pericarditis it's a form of chronic pericarditis where you have developed calcification of the lining around the heart, and it now has become calcified. And I'll show a picture of this subsequently. Dr. Selzman and I have shared a lot of patients with this, most particularly a world-renowned photographer, and who ultimately got constrictive pericarditis, presumably from some sort of mycobacterial infection. So the MRI becomes useful in diagnosing constriction because a lot of it is based on the motion of the septum, and it can be difficult to image the septum, especially in people who are more rotund. So we mentioned the differential diagnosis, and I didn't mention this, and this is where echo comes in handy as well as the other differential diagnosis of this ECG changes is Takotsubo's cardiomyopathy, so broken heart syndrome, stress-induced cardiomyopathy. This will also cause diffuse ST segment elevation. However, there will be wall motion abnormalities associated with it, in which case obviously the echo comes in handy. All right, so now we're going to touch on the treatment of pericarditis. With the treatment of pericarditis, this is a nice cartoon that this is essentially the rest of my talk, and we can just leave this up here and you can read, and we can all go home early. And so this is so you're in the acute phase, you're using NSAIDs and colchicine, and the NSAIDs typically are aspirin and ibuprofen. Now, for me at least, I use aspirin. I use high-dose aspirin. I give them aspirin until their ears ring. 975 of aspirin 3 times a day. Yeah, and just, they'll be grand. They'll be grand. It's just 2 weeks of just a lot of aspirin. And I do think from the John Ryan School of Anecdotal Medicine, I do think that aspirin is better than ibuprofen in this setting. And then you use colchicine. The role of colchicine, obviously, as we all know, is primarily is to prevent recurrence. But high dose aspirin, 975 milligrams 3 times a day, and we'll get you there. Now, then if they have recurrent pericarditis, then you're into a whole host of other things. Maybe you're using indomethacin, and I'll just go on to our next slides, and this is more of a summary slide. So with the colchicine, you try and use weight-based colchicine in addition to the aspirin or your NSAIDs. Now, the NSAIDs are gradually discontinued, and as your CRP normalizes, and this is why having a CRP at the very beginning that's elevated is very handy. Your NSAIDs, as I said, or your aspirin, you get rid of that after 2 weeks, or when your CRP normalizes. Sometimes I call it CRAP, but that's a different story. Or when your CRP normalizes, you gradually take your NSAIDs off. However, your colchicine you leave on. You leave your colchicine on for many, many weeks, even for months, about 12 weeks, 3 months. And the role of that is to reduce recurrence and actually reduce hospitalizations. Now, the adverse events rates occur fairly commonly, about 1 in 20 to 1 in 10, and that is GI upset. Everybody gets diarrhea. Everybody gets diarrhea. But more significant GI upset occurs in about 10% where it truly becomes intolerable. And you keep the colchicine going for about 3 months. Now, the corticosteroids, we've shared patients with this as well. The corticosteroids, I have never prescribed steroids for pericarditis. My name is John, and I've never prescribed steroids for pericarditis. Thank you, John. And I've never done it because when you do it, and if other people do it here, I'm happy to be challenged. The concern that I have is when you prescribe when you prescribe steroids for pericarditis, they will come up to you, they will say, my goodness, you are the greatest doctor I've ever met or healthcare provider I've ever met. You are absolutely amazing. I had terrible chest pain. I couldn't breathe. I was really uncomfortable. And now you've cured me. You are the best person I've ever met. And then 2 years later, they'll be saying, oh my gosh, I'll never forget that fellow's name. Worst doctor I've ever met, because you're still on the steroids. And you try and come down, and then your pain breaks through, and then you go back up again. Now you're having, as you all know, weight gain, hypertension, diabetes, etc. And the use of steroids is associated with a more prolonged course, and ironically, a higher risk of recurrence. You don't get the full healing with the steroids. Arguably, actually, low-dose steroids are better than high-dose steroids. So if you are actually use steroids of some form, you're arguably better to use low-dose. And that further feeds into this, at least theory, that giving high-dose just does not give the pericardium time to heal. So that's the concern with it. So I would encourage people to not use steroids. Certainly don't use opioids. And we have had scenarios where people are just so intractable pain 2, 3, 4, 5 years later that we end up doing pericardiectomy because it hasn't because they haven't been able to get rid of their pain. And also, actually, Craig and I had a lady from Idaho Falls or Twin Falls, I think. And the steroids obviously make it harder to heal as well, as you know, because you're on your steroids, you need a pericardiectomy, and your sternal healing obviously becomes quite problematic. So don't use steroids. Use a lot of aspirin, don't use steroids. The guidelines actually, which I was not part of, the guidelines actually recommend limiting your exercise activities. I actually don't agree with that because, first of all, in North America, most people are already limiting their exercise activities. I run a chronic exercise insufficiency clinic. And also, I mean, the idea is that your heart rate gets up and then you irritate your pericardium more. So that's why the guidelines recommend restricting that for 3 months. And that's just hard for me because then do you also restrict scary movies for 3 months? Or, like sex for 3 months? So I don't know, or just watch things that don't raise your heart rate. So don't watch the news. So there's various. So I have a struggle with that. I struggle with the exercise limitations that are recommended in the guidelines. As I said, 30% have recurrence, and the pathophysiology of the recurrence is different, and this is important as well. So the recurrence, actually chronic recurrent pericarditis, is not actually getting a viral infection. If we believe, let's just play pretend here and say that pericarditis is caused by viral infection. Having a recurrent pericarditis or chronic recurrent pericarditis is not caused by recurrent viral infections. It's actually a different disease state altogether. It's a reaction to your very first viral infection, which then triggers an IL-1, an inflammatory immune response. The primary part of the pathway is IL-1. Where this results in things which Dr. Selzman can talk most eloquently on, the NLRP3 inflammasome. That's got to be your favorite inflammasome, right, Craig? And things like PAMPs and DAMPs and various other inflammatory agents, ultimately resulting in pericardial inflammation, increased white blood cell count, increased monocyte activation, increased complement, and increased capillary leak. Everything in cardiology is about capillary leak, or capillary. So I talked for the PA school. I'm still the teacher for the PA school. I don't know why, for the cardiology curriculum. And the one complaint I got last year, because I would do my impersonation of American accents, and the one complaint I got last year was Dr. Ryan does not appear to like American people. Yeah, which I do like American people, and I now have 2 passports, and I am an American, so there you go. But in any case, so there's capillary leak, and again, this all comes down to IL-1. And in fact, Craig, to treat this, we need a cleanup in IL-1. You like that? Sorry, Jeff is funnier than me. Always was. We should update it. So your treatment of the chronic recurrent pericarditis. The treatment of the chronic recurrent pericarditis, it ultimately ends up being colchicine. You start off with colchicine. Some people use steroids. We don't. But there now actually is a more dedicated treatment available, and it is rilonacept, and it is an IL-1 blocker. And now you won't forget that. And good drug. This is whoops-a-daisy. This is a paper published in the New England Journal of Medicine on the role of rilonacept in chronic recurrent pericarditis. People are randomized to rilonacept versus placebo. And the top line is the people on rilonacept. And you can see that their recurrence rate was very low, and the placebo, the recurrence rate was very high. Because once you have a recurrence from your pericarditis, you will end up getting more recurrences. You're just phenotypically different. The funny thing about this is, and some have argued, well, why wouldn't you use anakinra? And which is also an IL-1 blocker. It's a daily injection. The rilonacept is once a week. The anakinra is daily injection. And the funny thing about that is that as we were treating over these years, as we treated chronic recurrent pericarditis. Well, here's a story. You want a story, Jeff? Can I tell you a story? Good. So I had a lady, and she had an insurance plan, which rounded like moo, boss, moo, mealed, and we want to treat her for chronic recurrent pericarditis. So we prescribed her anakinra. And got a letter back from their medical director, said, you cannot use anakinra, it's not approved for treatment of chronic recurrent pericarditis. I thought, all right, fair enough, it's not, but fine. Ultimately, she ended up being diagnosed with lupus, so we got her on anakinra and everything was fine, and her pericarditis got better. Then rilonacept came out about a year or 2 ago, and wrote the first time I wrote for it, wrote a letter. I said, this person needs to be on rilonacept, wrote my prescription. Got a letter from the same insurance company, and they said they shouldn't be on rilonacept. They should be on anakinra. Yeah, and I was like, well, the last time you told me they couldn't be on anakinra. So ultimately, the insurance process has gotten better. It is a good drug. It's once a week. But again, if that doesn't work, it's an injection. If that doesn't work, then if they truly have a poor quality of life, they are absolutely miserable. People with chronic recurrent pericarditis, they are miserable. And part of the problem that with people with chronic recurrent pericarditis that they have is that they don't look sick. And you probably have loved ones or family members who've been within that boat where, oh, you're miserable and you're sad and you got chest pain, but you don't look sick. And that's a really difficult scenario to be in. And actually, the biggest problem that they have is they have a lot of depression, a lot of anxiety, and a lot of missed days from work. So in that setting, many of them do embrace the idea of pericardiectomy for the treatment of that. The complications of pericarditis we've mostly touched on, and they are cardiac tamponade, which many people here in the room here will be familiar with, where you have your left ventricle, right ventricle, and then outside you have the fluid around it, namely pericardial tamponade. Constrictive pericarditis, which we've touched on a lot already, where you have calcium around your heart. You can see that on CT scan, and then ultimately do a stripping procedure. And then a condition referred to as effusive constrictive pericarditis, which is almost a combination of the two of those, where you have fluid and then you also have pericardium around it, or calcified pericardium around it. So there are complications of pericarditis. The best way to avoid them is a little unclear, but probably try and decrease the inflammation. So in any case, so acute pericarditis remains the most common form of pericarditis. It's generally benign, but it can have significant complications. The most significant of which, or the most common of which, is chronic recurrent pericarditis. The etiology, prognosis, and treatment of pericarditis varies. Even within this room, the practice patterns would vary. Imaging studies, in particular echo, are essential for the diagnosis and ultimately for treatment. And then if they do have recurrent, you consider IL-1 blockers. And then refractory cases require consideration of pericardiectomy. So this has been a real treat. Thank you so much for having me out. The bulk is driven by our pulmonary hypertension Utah care team. We have our own abbreviation there, which you can enunciate yourself. If you want to contact me for any cultural sensitivity reasons, please feel free to call me or email me. This has been a real treat. Peace and love, and I'll take any questions.
As you know, I have no role in life today except to harass the people. Anwar was upset when he found out that I wasn't giving a talk. Dr. Ryan has successfully made a topic that usually lasts about 3 minutes, 3 hours. So thank you for expanding into that. A couple of questions for you, John. I've heard you give this talk before, but I don't remember this very Machiavellian approach to aspirin. And it's just, that's a huge dose. And I'm just wondering if you have any data to support what you're doing.
I mean, it's on the curriculum in the John Ryan School of Anecdotal Medicine. It's a big curriculum. So in broad strokes, there is some data about, obviously, that there is no head-to-head trials of aspirin versus other forms of NSAIDs. Yeah. For what it's worth, yeah, Rick Nishimura does the high doses as well. When I was in Boston, people do the high doses as well. So it really is truly, you'd be surprised. Yes, it's a high dose, but it's only 2 weeks. A lot of the time, the people are young, you know, they're 20-year-old college students. They're doing a lot worse to their stomachs than high-dose aspirin, except in Utah, I guess. And you do get away with it. I mean, you can give a proton pump inhibitor with it as well. To be honest, most of the time, I think you're just being, you know, you're obviously being prophylactic with that, as well as a H2 or, you know, some sort of H2 receptor blocker as well. So in terms of overt clinical data, no, I don't have any. But I do feel that it works very well. It's tolerated. I've rarely had someone come off of it. It's tolerated more than you would expect.
I'm curious, there's some medical heart doctors here. How many have used aspirin as their sole therapy for pericarditis?
No, none.
Usually,
Dave?
high-dose Motrin, is that?
Oh, is that what you're using? Okay.
First one. So
Okay. All right.
there might be mutiny here, or you might have taught us something.
Yeah.
Which is awesome. I know that I'll try that the next time. It's probably better tolerated than, you know, 3 times a day of super high dose prescription level Motrin.
Yeah, I think it is. Yeah. Yeah. Oh, sure. Yeah. So the comment being hemorrhagic, the comment being obviously concerned about hemorrhagic pericarditis in the setting of aspirin. And that's fair, obviously, with the aspirin antiplatelet effects. But at least you would hope that, yeah, your echo presumably would guide you that there is not at least a horrific effusion going into it. Yeah, but yeah, no, that's a good point.
Your treatment based, like vary based on the cause when you see the acute patient,
Sure.
or you put every acute patient on the same regimen?
I do everyone on the same regimen. Your older folks who've had the AFib ablations or the pacemakers, etc. I am more timid with their aspirin dosing. So I do, personalize in that regard. But again, if it's a, 22, 24-year-old college kid, I just go all out. But yeah, your procedural I change, not necessarily because of the procedure, but because of the population that is affected. And obviously, going to the comment that our colleague made, obviously, if it's cancer-related one, with your breast cancer, melanoma, most particularly, then again, I would not be as aggressive with the high doses because of the risk of more hemorrhagic conversion in that population.
So who's monitoring the Zoom? You are?
Is there anyone on?
Question in the chat?
Or anyone at all?
Is there a meeting that actually on? Like that too?
That's good for the 10 meetings.
Is one of them named Hoffman?
Yes, better to know.
How come she didn't want to come say hi? This is the person, I'm looking at you right in the camera. Another question. If there's a 30% recurrence rate.
Yeah.
When did you decide to use the interleukin-1
Sure.
antagonist as first line therapy as instead of, well, how are you using it? Do you use it at first line or is it only salvage for the recurrence?
Yeah, that's a great question. So with so you have your index episode of pericarditis, and then you have your second episode of pericarditis, your first recurrence, I guess. I will go with my aspirin colchicine combo in that. And then it's kind of like, then once you had your second recurrence, so your third episode of pericarditis altogether, that's when I do try and start IL-1 blockers.
Any
So
thoughts of moving a little bit earlier?
you could, because obviously once you've had a second, when you look at the recurrence episodes, unsurprisingly, 30% have one recurrence, and then 50% of that 30% of another recurrence, and then obviously the numbers go up higher. So we end up playing the numbers games. There are people who do use it in that second batch, the second event, but I don't. Yeah, but there are some people who do. Strictly speaking, the licensing does require 2 or more recurrences. The licensing does require 2. So 2 or more recurrences, which is 3 episodes altogether.
When we think about the patients that we end up doing, it is pretty unusual who we do total pericarditis.
Yeah, it is. Yeah.
Pericarditis.
Yeah,
It happens.
it does.
But usually there are people that have been struggling for years and years. And it seems like the inflammation is just kind of set up.
Yeah. Yeah.
So that if you could really cut it off.
Yeah.
Early on and very aggressively, that you might be.
Yeah, because one of the things that I have noticed with the rilonacept use and the chronic recurrent pericarditis is actually one of the few things we, on our side, the medical cardiology side, we don't have a lot of wins. We give you statins, we give you aspirins, but it's very rare that we have I felt miserable and now I feel great. Obviously, our interventional cardiologists do that, in the setting of STEMI, but in a clinic setting, in heart failure, in pulmonary hypertension, yes, you're asking them, do you feel better? And they're like, yeah, I feel a little better. And they're just, they're just saying that to be nice. You know what I mean? So on the medical side of things, it's the rilonacept or this IL-1 blockade is different because they truly go from being miserable on their knees saying, this is, the worst experience of my life. And then they come back in and they're fine. It's crazy.
Yes, sir.
For some of your practices, like the world loss, you use CT scan.
Yeah. Yeah. So the question is that if you're in a rural community where you don't have readily available access to echo and there might be a delay by 2 or 3 days to get your echo, would you use a CT scan to assess for the presence of an effusion? And there was a second part to that. Oh, sure. And what criteria would you use to decide if they need to go to a bigger facility? I think, so yes, I would use a CT scan to assess for the presence of pericardial effusion. If you don't have an echo, just do a CT scan. If there's no pericardial effusion or trivial pericardial effusion, then you're grand. If there is a large pericardial effusion, and then I would recommend transferring to getting your echo sooner, because you need to figure out if it's tamponade or not. I mean, that's your issue. You need to figure out if it's tamponade or not. So yeah, so I would transfer in that setting. And why are you pointing at me? Why the hell are you pointing at me, man? You asking a question? Oh, you want to say something? You're going to have a whole 45 minutes. Go ahead. Oh, yeah. So what Dr. Chandar is interrupting me to say is you can, if you obviously access to portable ultrasound, some sort of POCUS point of care ultrasound that's becoming increasingly common. That's obviously helpful. It's the most helpful thing Dr. Chandar has said in a while. We done? That's it? You're walking, you're getting me off stage? Yeah, exactly. Carmela, we good? All right, peace and love. Thank you.